Thank you.
So next I invite Dr. Mohammad Shahbaaz. He will be speaking on the endothelial grafting, thinner the better. Dr. Shahbaaz is Medical Director at Trinity Eye Hospital, Coimbatore.
Good afternoon, everyone, and thanks, Sujit, for inviting me here. So we know like endothelial keratoplasty is just changing the internal layer of the cornea and leaving all other structures as it is. And there are a lot of like evaluation if you see from DLAC, DSEC, ultra thin DSEC, DMAC, and only Desmond membrane removal. So this is like figure you see what Sujit has asked me, thinner is better. So we have gone from thick, thin and thinner. So both the things are there. Thinner is definitely better, recovery is fast, results are better, but the surgical skill you require more in that, and it's become more challenging for implanting the thinner buttons. So what are the indications? Like we'll just skip this. So Desmond membrane endothelial keratoplasty was started in 2003. And this is like manual dissection, which I'm so this is a case like it's a bit complicated case. Multiple things are there. You have BSK, you have endothelial decomposition, and cataract. So I'm just nowadays I don't use EDTA. Before starting, we were using now just manually scrap of the epithelium, and this Tooks blade works very well. I feel that is as good as a diamond bar of Sir, because it's clean the epithelium like anything. If you see that after removal of this, it will be crystal clear. Like, and to this extent, you can just this is the Bowman's membrane. We can remove the Bowman's membrane also. And I usually mark the cornea, and as usual, two side pores. And this is one observation I have saying. If the endothelium is not healthy, it gets stained with this strip and blue. Before I was never knowing this. Because of the cataract, I have done this, and then I saw this endothelium become blue. So this we can do in other case also, but by and large, because endothelium we are removing, so even if collapse, even if it's distort, we don't worry because we have to remove this. But it's become blue. That was like my observation in this case. And then usually I make 4 millimeter, and the manual dissections, as I was telling, thicker. Usually we cannot judge how thick it is, and most of the time we'll end up having a thicker graft because we are more worried about going towards the endothelium. I do dissection like open sky dissection. We will have lamellar dissectors. I don't use nowadays. Initially I was using, but in that I was not feeling very comfortable. So I just use crescent. You just open it up and keep on dissecting, and you can remove. So now we can do this layer we can use for anterior limb transplantation also. So marking is not very important, but the graft is slightly thick, so it's open up very well. I'm doing a taco technique, and just I'm doing a PI because I leave air after. I don't remove air. Just you fold it and see that it open up very well, because it is slightly thicker, so it has rigidity is still maintained. As you become thin, the rigidity is gone. So you have to manually open it, and that becomes more difficult. And this is the results you can see. This is a pre-op photograph, and this is day 1. And this is after 1 week. There's some amount of haze is still there, but this is a very complicated case, so we expect that haze. Now DSEC, if you see, as the advancement has come, you have a microkeratome. You can dissect the anterior layer with microkeratome, and the thickness you can, depending on the head, you can have even thinner graft. So you can go more thin and more smooth surface. If you are dissecting manually, it cannot be smooth. The different layer it comes. So this is like pre-cut tissue we got. And you just lift the tissue. I usually mark, because in DSEC it's not necessary to mark, but if you mark, you are more confident that the graft is in correct position. And this is a thinner graft. You can see it's like more flimsy and more like. Just remove the epithelium. It's better to mark the side port point because sometimes it's very difficult to search where it is. So nowadays I usually mark. Initially case I was not marking. So when you are removing under fluid or air, the chamber start getting collapse. When you're removing under visco or viscot, the chamber do not collapse. But there you have to wash it thoroughly. When you are doing cataract, in that time when you do AC wash it comes up very well. Now this is a floating descending membrane. I do dissect the cornea up to the mark which I have done so that the graft itself can cover that. So requirement of suture will not be there. And as I put full air, so I will always do an inferior PI. And it's very simple, like just take a cutter and go and make a small PI. So this I made as sheet glide, like plastic sheet. I have not gone for sheet glide original, just make a plastic sheet and put the graft over that and just slide it. Because if you make taco of this graft, it do not open up very well. So I wanted to go like straight. Now it has come in the center. The air bubble should be very properly put because if you put in the side, the graft will move towards one side. So you have to be very careful here. This is also slightly decent, but this thick graft, this much thick graft, you can just with a spatula, if you shoulder it, it will come to the center. This video I don't have. Then ultra thin dissect, even as I told you, the head depends on the head. You can make it thinner. And then the DMEC. The beauty of DMEC is that even after surgery, you cannot recognize that some corneal transplant has been done. So I usually go with larger trephines, just score the descending membrane to some extent, and then cut it with the appropriate side. Usually 8 millimeter we use. And after doing this, I come towards this cataract. This was again cataract plus DMEC. So I have done cataract surgery. The visco is there. So it's very comfortable and easy to remove descending membrane in these cases. So both the side. You have to be very careful. You should not go too deep. If you go too deep, it will take up the stroma and then it will not come. So you have to just be superficial, like from back side. And once I have removed that stroma, I was trying to remove it with IA probe itself, but it doesn't come. So I just remove it in toto and then pilocarpine and then PI. More staining is always better because if you have to maneuver 2-3 times, the stain goes. So better staining, leave the graft for some time so that it gets folded. And now here your luck. If it comes in one go, it is good. Otherwise you keep on. So I always have an additional cornea, spare cornea, whenever I am doing DMEC. And if this graft doesn't set very well, I do a dissect for that. So dissect is like your SICS. When you are not confident about phaco, you come back to SICS. The result of both are almost same after 1.5 to 2 months. But yes, if you see the initial result, like day one, if you see, it is like, it doesn't look like that any procedure has been done. And 1 week air bubble is gone and it is absolutely clear. So thinner graft have faster and better recovery comparison to thicker graft. Thinner grafts require more surgical skill as placing of the graft in the center and correct orientation become very difficult. So end result of both the surgery I feel is same. After 2-3 months, if you see, it will be like even dissect button become very thin. So you don't feel like there is too much difference. Thank you.
Thank you, Dr. Shahbaaz. Wonderful videos.